All right, so we're moving on to cystic fibrosis. So we'll be talking about this. So cystic fibrosis is a genetic disorder. It is an autosomal recessive multi-system disease that affects the exocrine glands. So there is an alteration in the transport of sodium and chloride in and out of the epithelial cells and out of your skin cells. And it primarily affects the lungs, the pancreas and biliary tract, and the reproductive tract. So the CFTR protein actually alters the transport of sodium and chloride. So this is the protein that really is responsible for this autosomal recessive disorder. So because of the problem with sodium and chloride, it leaves the cells without water attracted to it, and what happens is there's like dry mucus that winds up building up in these systems, the lungs, the pancreas, the biliary tract, and the reproductive system. About 30,000 children and adults in the United States have CF or cystic fibrosis, and about 1 in every 31 people are carriers. So since it's a recessive genetic disorder, patients can be a carrier but not have the disease, but can wind up passing it on to their offspring. So back in the early 90s, the median age of survival for patients with CF was around the age of 30. And now it's progressed because we have a lot more treatment options available and a lot more research going into CF, that the median age of survival is actually around 50. So a little bit more of what happens. So there's obstruction of ducts, of the exocrine ducts in the lungs, pancreas, and intestines that is caused by this really thick viscous secretions or mucus. So this mucus actually plugs up the glands in these organs and winds up causing atrophy and then leading to organ failure. Primarily, we see this mucus buildup and this CF mainly affecting the lungs. Some of the symptoms, it can start off as like a chronic bronchitis type symptoms, and then it eventually leads to the destruction of lung tissue over time. And this is why patients usually don't survive with CF. It's due to lung destruction. In addition, this thick mucus in the lungs likes to trap a lot of germs, so they commonly have respiratory infections. And as we know, with frequent infections, you treat those with antibiotics, and frequent antibiotic use can lead to the development of resistance, so resistant bacteria. So then it's even more difficult to treat these patients. So because of the destruction of the alveoli and the pulmonary tissue that happens because of the viscous secretions, bleb and large cysts wind up developing in the lungs. And then complications of CF, where we usually see patients not doing well or progressing poorly, is hemoptysis, which can actually be fatal, and it damages the pulmonary vasculature, which can also lead to a pneumonia hypertension. Pneumothorax can be seen, especially with the blebs, because rupture of those blebs can lead to air leaking into the pleural space, causing a pneumo. And then eventually death is usually resultant from loss of pulmonary function. As far as the pancreas, so the mucus plugs up the pancreatic ducts of the exocrine pancreatic ducts, right? So this alters the digestive system. So we're unable to release the digestive enzymes such as trypsinogen, lipase, and amylase that help to break down carbs, fats, and proteins to aid in digestion. So we're unable to absorb, obviously, if we can't break it down, the fat and protein, and we're also unable to absorb fat-soluble vitamins because we're unable to absorb fat or convert the fat because of those enzymes not being released. Especially in children, if CF is not readily diagnosed, which is uncommon in the United States, and we'll get into that, usually you'll see a failure to thrive in infancy. So our fat-soluble vitamins are A, D, E, and K. So D is responsible for bone health. So this is why osteopenia and osteoporosis can be fairly common in these individuals, because they don't absorb the vitamin D that is needed for bone health. Steatorrhea or fatty stool fatty, very foul-smelling stool is common in individuals as well. That's because they're not breaking down and absorbing that fat. Instead, it's just being, released into their stool. It's going through the intestines without actually being broken down and absorbed and used for energy. CF-related diabetes is extremely common. Over 50% of people with CF have cystic fibrosis-related diabetes, and this happens because the pancreas is, destroyed or atrophied over a period of time, and then that also destroys the endocrine functioning, which is insulin production. The liver and gallbladder can also be affected by mucus building up in those organs, leading to gallstones. Let's see what else here. So DIOS is distal intestinal obstructive system. So this develops because of a chronic malabsorption and dehydration. So there's not a lot of, availability of fluid to help digest or to help pass through the intestines, leading to basically constipation. So these are some of the early manifestations that we see in infancy. So nowadays in the United States, every infant is screened for cystic fibrosis. So we really don't have the guessing of symptoms and could this be CF, because generally it's caught early on, before even the patient leaves the hospital, before the infant leaves the hospital. But some of the early manifestations that can be present are meconium ileus in the newborn, acute or persistent respiratory infections, which usually this is the big indicator, of that they might have some underlying pulmonary condition. Failure to thrive or malnutrition because of the decrease in absorption that they have. Those very fatty stools, statorrhea, large protuberant abdomen, emaciated appearance of the extremities because they don't have the absorption of the protein, fat, and carbohydrates, and bronchiectasis, which is, frequent infection of the lungs. So the first symptom in adulthood is usually a frequent cough that becomes persistent. Generally, patients do have bacteria in their mucus, so it can appear very viscous, purulent, and have like a yellow or greenish color just because of its bacterial presence, because bacteria loves warm, wet environments, and what else is the best for that other than our lungs, right? Without treatment and over time, or as the disease progresses, there's exacerbations of the cough because we're unable to propel that mucus outward. There's weight loss because of malabsorption of those enzymes and fat-soluble vitamins, increase in sputum, exacerbations become more frequent, there's loss of lung function, and ultimately this results in respiratory failure. For patients who do have DIO, so the distal intestinal obstructive syndrome, some of their symptoms that they may have are right lower quadrant pain, loss of appetite, nausea, they might vomit, there might be a palpable mass. So we do want to ask patients about their bowel regime and their stools. And also doing a full abdominal assessment to make sure that they are not at risk for DIOS or have any symptoms related to this. As far as the reproductive system, both males and females have delayed puberty. In males, the vas deferens is destroyed, so that is the route that brings the sperm out to where it needs to go. So it's not that there is infertility, that the men don't have good sperm per se, it's just that that sperm can't get out the natural way to where it needs to go. So they do have the capability of having a child. There's just other methods that may need to be utilized in this circumstance if they don't have a vas deferens or if it's destroyed in some manner. As far as females, they do have menstrual irregularities, and they may be unable to become pregnant. However, especially nowadays with a lot of treatment, many females, if they can become pregnant and do become pregnant, do fairly well. The thing that withholds them from becoming pregnant is a lot of times there can be a lot of mucus that develops over the cervix, and therefore there is, obviously sperm that can't get into the right place to become pregnant. But pregnancy is not a problem. So as soon as they do become pregnant, as long as they have adequate pulmonary health and they're on top of their nutrition, they do fairly well with their pregnancy. So they don't put the baby at risk by being pregnant just because they have CF, in other words. However, if one parent has cystic fibrosis, there's a 50% chance that the child will have CF. So there's a lot of education that needs to be done with patients with CF who do want to start a family. So the gold standard diagnostic test is the sweat chloride test. So if you watch a video that I posted in Blackboard, you'll get a good idea about what this test, what it entails. But this is really the most diagnostic. Nowadays, every infant has a heel prick at birth. So this heel prick does a whole bunch of different things. We can gather a whole bunch of different tests. And one of the tests that we do is we put that blood sample from the infant on a Guthrie card at birth, and this screens the newborn for cystic fibrosis. So if this Guthrie card testing comes back abnormal, then they would be, it would be suggested that they go on to get the sweat chloride test. So that Guthrie card is really just a screening. It doesn't determine whether or not they actually have CF. So since CF is a recessive genetic disorder, both parents have to have at least one copy, one defective gene in order for that to be passed on to the child. So generally in genetic counseling, when people are looking into having a child, if I had genetic testing done and it was noted that I'm a carrier for CF, it would be suggested that my partner also be tested to be a carrier for CF, because then I would know that my child has a 25% chance of having CF. If my partner was not a carrier of CF, there would be a 0% chance that my child would have cystic fibrosis. They could be a carrier, but they would not actually have the disease. So both parents have to have a copy of the defective gene in order for that to be passed on to the child. Another thing that I want to make note of too is there's so many genetic alterations for cystic fibrosis. It's not just one gene that's altered. There's a lot of genes that could be altered or could not be altered. So if you ever go to the CF website and look up cystic fibrosis because you want to be a good student, you can see all of the medications that kind of target specific genes. And that is because there's many different types of genes that could be affected for CF. And some of these genetic alterations can really determine. Oh my God, her eyes are open. Like, you look so pathetic right now. These bugs are biting my butt, so don't even worry about it. It's not even fun out here.
That's being involved.
I'm going to test you on cystic fibrosis after.
Okay.
So our collaborative care involves promotion of clearance of secretions, which we will go through. Controlling infection in the lungs is extremely important since these patients are very prone to lung infections. Providing adequate nutrition, which includes taking a supplement before every meal. And then managing pulmonary problems, like if they have airway obstructions, getting to the root of that. So these are some of the medications that are used to help dilate the airways and liquefy mucus to facilitate clearance. DNase is pretty specific to cystic fibrosis, whereas the other two, the inhaled hypertonic saline, can help facilitate coughing. And then bronchodilators obviously can dilate the airways to help that mucus come out. So since getting those secretions out of the lungs is one of our goals in maintaining or in treating cystic fibrosis, we have these airway clearance techniques, or these ACTs as they're commonly referred to. So some of these ACTs include chest physiotherapy, or CPT as it's demonstrated in your slide. There's this high frequency chest wall oscillation systems, which is basically that vest that shakes the crap out of you. Postural drainage. So this is getting in certain positions and having somebody percuss over an area of your lung. And generally, patients are in reverse Trendelenburg during these postural drainage sessions. And while somebody is percussing, they're hopefully moving that mucus upward toward your greater airways to help get that mucus out. There's also PEP devices such as the Acapella or Flutter devices that help shake up that mucus to help get that out again. And then there's breathing exercises. They have this thing called huffing, and it's not what you think. It's actually learning how to get air deep into your lungs to help kind of get around that mucus and push it upward. If you Google huffing for CF, you'll see that there's these different breathing techniques. I've tried them before. They're difficult. So really all of these airway clearance techniques, we really want to clear that mucus out of the airways to defer that atrophy that can happen with lung tissue. Patients can use one of these, so maybe they use those chest vests that shake and vibrate. Maybe that is their ACT preferability. Other patients use a combination of these, so it's really patient dependent and what works best for them. This is just a picture. It's a brand name Acapella, but this is a handheld device that can be used by CF patients to help shake the mucus and help propel it outward. Aerobic exercise is encouraged in CF patients, so we do want patients exercising because it can be effective in clearing the airways. They may need frequent rest periods, and that's okay, but aerobic exercise is good for them, so we don't ever want to limit their activity. We just want to encourage activity as tolerated. So we know that patients with CF have this alteration in sodium and chloride transport, so they have very salty tasting sweat. So when they sweat, they also excrete a lot of salt. So in somebody who is sweating a lot, either because they're in extreme hot weather, or maybe they're exercising in hot weather, we do want to make sure that they are supplementing that with salt in their diet. But if patients are not sweating a lot, or if they're doing mild exercise, they do not need to supplement their diet with salt. So it's only patients who are sweating excessively that we really want to encourage them to add salt to their diet. In addition, liquids is so important. I used to work with a girl who had cystic fibrosis at St. Pete's early on in my nursing career, and she always carried around this huge jug of water because it was so important for her to make sure that she had enough liquid in her system, enough fluids to help liquefy some of those secretions. And that's important even if patients are exercising or are not. So they should be drinking a lot of water to help liquefy that mucus. Treating pulmonary infections early is also very important. So unfortunately, these patients require a longer term of antibiotic use. Some medications can actually be inhaled to help decrease the systemic effects of antibiotics. The longer course of antibiotics is due to the drugs being abnormally metabolized and quickly excreted, so they do need a longer course of those antibiotics, especially if they're taken orally or IV. Oftentimes, patients will have routine like sputum samples that they will submit to their healthcare provider to help screen for any bacteria to help identify if they're, have an infection in place to treat that early before they become really symptomatic. And again, there is problems with drug-resistant antibiotics or drug-resistant bacteria, which is really hard to treat with certain antibiotics. So that is a common concern with patients. So because of the pancreatic insufficiency, patients need to take pancreatic enzyme supplements prior to every meal and snack. So even if they were having an after-school snack, it's very important that they take these replacements. So some of the replacement names are like pancrease, So that's one of the, pancreatic supplements that they can take. In addition, they also take supplements of fat-soluble vitamins because they're not absorbed as well. So we want to make sure that we're, having enough of those. So hopefully we can aid in absorption. The polyethylene glycol or PEG electrolyte solution is for that DEOS that can happen. So to help liquefy some of their stool. Miralax can be used, which is a bulk laxative, so it helps pull fluid into the intestines. And then Go Lightly, which is if you ever had Go Lightly, we know that we do not go lightly with Go Lightly. I don't know who named that, but they're wrong. But that can also be something that is used to help manage that DEOS. Some of our nursing management for CF patients include adequate airway clearance. So this is those ACTs that we talked about earlier. So whatever the patient prefers in propelling that mucus outward or upward, reducing the risk factors associated with respiratory infections. So some of those include hand hygiene, making sure that they have adequate vaccinations, and also keeping their nebulizers clean. Since they do use a lot of nebulizers, generally they'll use them 4 times a day with their ACTs. So they will do those airway clearance techniques 4 times a day. So if I were a child in school, I would wake up in the morning and prior to school, I would do let's say my chest physiotherapy. Maybe I'll have my mom percuss my back for, 20 minutes. While I'm doing that, I'll also use my bronchodilator to help dilate my airways to further help propel that mucus outward. And then when I go to school, during lunchtime at school, I would also do that. Then I would do that after school and then again prior to bed. So usually this is done 4 times a day. Adequate nutritional supports. This is making sure that many times CF patients are very thin, but making sure that they have adequate supplements to supplement for those pancreatic enzymes. Assessing their ability to perform ADLs, which would help us in determining whether or not their pulmonary function tests were declining. And it is so important that patients really understand the treatment plan and the therapeutic regime for managing cystic fibrosis. It's really a family approach because many times, especially in the United States, they're diagnosed young as infants that we find out that they have cystic fibrosis. So it's really a holistic approach, and patients need to take accountability for their disease in order to have a long life and quality of life, of course. So if patients start having more exacerbations or more problems with relieving some of that sputum, we may increase their ACTs to like 4 times a day to make sure that we're help facilitating movement of that mucus outward. Also early treatment of respiratory infections, so making sure that they're treated with antibiotics appropriately, following up with sputum cultures, and taking their full course of antibiotics to help decrease the incidence of resistance. So part of nursing management, continuing on, is to help patient assume responsibility for their career and goals. So there are actual CF centers. So Albany Med is a cystic fibrosis center. So these centers have physicians, nurses, nutritional therapy, case management, respiratory therapists that are specific for cystic fibrosis. So it really creates a holistic approach for these patients, since it's really a multi-system disease. Also discussing with the patient their altered sexuality, so whether that be delay in puberty or maybe them wanting to start a family, really discussing what that entails. Most importantly, it's providing relief of bronchoconstriction, airway obstruction, and airflow limitations, since pulmonary decline is generally the result of these patients not doing well later in life. So cystic fibrosis is really something that patients need to own and really need to be involved with, both parents and the patient themselves. And that pretty much sums up our CF chapter.